respiratory therapists are. I see we have a big turnout of respiratory therapists. Yeah. Big hand to Harold. I guess it's his oatmeal time.
Already had it.
Already had it? All right, come on up front because you're going to be our victim. Okay, because can you bring an ADO endotracheal tube? And,
an ADO endotracheal tube?
Because we're going to intubate.
Harold, honey, I think 8'5", at least. 9. 9?
We wanted to do a live demonstration with Harold. He had volunteered yesterday. He said, you can intubate me. Everybody can take turns trying to intubate him.
And we're gonna, hey, Harold, we're gonna use a 990 on you.
Don't worry. We won't have to sedate you. We'll just paralyze you. Anyway, just grab a seat. I'm just, I'm going to pick on him all morning. All right.
Do you want?
I'm kind of like stuck between two things that I'm doing here. But what happened to my thing? I'm going to hold on to what you have. I've kind of hastily put together just some of the meat of ventilators and stuff, and so you can kind of use those, and I'll try to explain some of the graphs to you as I go along. And I'm going to try to make my talk, as always, fairly simple and straightforward as I can make it so I can understand it. Let's start with ventilators. I don't see any...
Listen, they do know that you're going to talk about ventilators even if they're not. They're just going to excuse you and not pay attention if they're from the floors. So do not pay attention to that.
Yeah, I mean, regardless, I'll try to keep it straightforward as possible, so at least you understand the physiology and mechanics of ventilators as well as I can make it. Going back in time, remember historically, if some of you might have read in medicine textbooks perhaps, or nursing textbooks, in the past, why do we use a ventilator? We use a ventilator when a person cannot breathe on their own capacity. So breathing on your own capacity could be, is it a problem of the lung itself, where the lung is diseased? Today we talk about COPD and pneumonias and ARDS and all that stuff. In the past, back when ventilators first started, early, let's say 1900s or something in that neighborhood, people like polio, for example, which is a neuromuscular disease, where there's nothing really wrong with the lungs, but it was the mechanics, the rib cage, the muscles that could not work, and therefore somebody had to breathe. They were paralyzed, so to speak. So in that situation, they had what we call negative pressure ventilators, where you've seen those big, bulky tubes, the MRIs of the past, where the body is in the machine itself. They're pressure controlled in the sense where you got a seal around the neck, and then the thorax is covered. And in the machine, basically what's generated is a vacuum, a negative pressure. So what happens is the vacuum occurs, the rib cage rises, and the lung can expand from that. So that was what we call the negative pressure ventilators. We don't use those anymore, of course, because they're pretty big and bulky. Today we have what are two kinds of ventilator. Well, a machine has multiple capacities, but what we call pressure-controlled and volume-controlled ventilators. And so now, if we look at how we breathe, remember we breathe air in. In our chest, we do have a negative, currently we have a negative system. When our rib cage expands, we generate a negative pressure inside the thorax, and that helps expand the lung up, okay? So as we breathe in and the rib cages expand, it creates a vacuum inside and the lungs expand. And we breathe out, we create a positive pressure. As the muscles contract, we kind of squeeze, and therefore a positive pressure in the lung tissue and the airways to breathe out. So if we break down ventilation, we basically have two things: what the patient can do and what the ventilator can do, okay? For example, what you and I can control is our rate of breathing, how big of a breath we take in, the volume of our breath, right? So if you say, okay, breathe fast, you can breathe fast and deep, or you can breathe fast and shallow, or, you control those two things, rate and tidal volume, if we look at it that way. And so on our ventilator settings, you know, we got rate, we got a tidal volume setting, and when you multiply rate times the tidal volume, so if we have a rate of 10 breaths a minute or 20 breaths a minute times a tidal volume of 500 cc's, that's what we call a minute ventilation. Okay. So on this diagram, you know, you look at, as we breathe in, tidal volume, you start taking a deep breath in, inspiration, and then it stops, and then you exhale. This is more of a passive function. It just happens. You don't force yourself to breathe out. You kind of relax and then breathe out. So this is an active kind of part of our respirations. I keep losing. That's why I'm not a good talker. Don't ask me.
I'm sorry.
I'm going to kind of skip this part for a second. Now, here's some of these graphs that I want you to look at. On the spontaneous breathing graph, you know, that's what I just kind of talked about. On that first sine wave curve, PAW means positive air or pressure of airway itself, and then the dot with the V is what we call minute ventilation, and V and a T is a tidal volume. And then all the different settings are what we call pressure graphs on the ventilators. We breathe in, it's a negative pressure. As we breathe in, I told you, we create a negative pressure, a vacuum. And then we have a positive pressure when we exhale out. So this is what I just kind of talked about. And then this is when a ventilator is doing it. The ventilator acts opposite of how our body acts. It's pushing air in with a positive pressure as opposed to a negative pressure like on the iron lung. So positive pressure going in, and then sort of a negative pressure as we breathe out. This is just sort of the same thing I showed earlier. Now these graphs, I want to kind of just show you these as we kind of talk about ventilators. There's different settings on ventilators. And I know I'm kind of going to jump around a little bit just because my mind's at 10 places when I'm talking. Let's start with the simplest thing. Let's take a patient who you have on the floor with COPD. They're having a harder time breathing. You say, hey, this patient is, Dr. Patel, you know, he's having a little more shortness of breath, he's a little tachypnic, he doesn't look right. And I'll say, okay, well, what's his vitals? You know, do we have an ABG, et cetera? What's his O2 sats? And if I know he has COPD, sometimes we'll say, okay, we'll get a ABG on the patient. So let's make it clinical in the sense. Let's take a patient as an example. We'll go through these settings for a particular patient. So on the floor, you have a guy who got admitted yesterday night. He's on breathing treatments. He's on steroids. He's wheezing a little bit, and he's breathing 30 times a minute. So you're coming on shift, and the nurse said, oh, he looks okay, he's sleeping, and you walk in the room and say, this doesn't look right. So you call the doctor and says, this patient just doesn't look right, he's breathing a little hard, he's wheezing, and the doctor says, get an ABG, okay? Or you might prompt him if you're concerned about the patient if he doesn't have an ABG. Because we'll use COPD because we see more of that perhaps on the floor, so you're better accustomed to watching out for a patient like that. In COPD, chronic obstructive pulmonary disease, emphysema is another thing. If I digress, COPD is like a big umbrella diagnosis. So it's got emphysema at one end where the lung tissue is all damaged up, chronic bronchitis at another end where they have bronchial tube inflammation and a lot of mucus secretions and plugging up the airways, asthma for a long time, chronic severe persistent asthma can give you COPD as well. So it's not just smoking related diseases, it can be other causes as well. Bronchiectasis is another one under COPD. People with COPD, you might have their O2 sat at 90, 94%, and so, well, he's fine, but you know, the guy's breathing 30 times a minute, his heart rate's up to 110, you know, his blood pressure might be okay, but he's working a little hard to breathe. And it's 10 p.m. at night, you're a little concerned before the code blue gets called. What you want to do with that patient is, A, if you don't have information earlier or the doctor isn't aware of any additional information, says, well, you know, this guy looks a little unusual. He looks like he's working hard to breathe. You know, you might want to get a ABG. They're already on breathing treatments, hopefully, and steroids and stuff like that. The ABG, why is that important? Not the same crowd. Does this thing go up and down? Yeah, I was going to try to write on the board a little bit. The ABG things that I want you to kind of focus on is three things, of course. You already know the SAT on the finger, most likely. ABG, you got a pH, PCO2, and PO2. Pretty much that's all I want to kind of hear about. I mean, I can understand what the SAT will be from what your PO2 will be on it. I can guess at that. But I'll just write with my fingers. Do you have an eraser by chance? Oh, there it is. So on the pH, what you're looking at is a range anywhere from 7.35 to, let's say, 7.45, okay? On the PCO2 part, you're looking at a range of anywhere 35 to 45, and you can kind of see these numbers sometimes come out similar. That's the PCO2. And then the PO2, you know, it can vary anywhere from the normal, these are the normals I'm writing. It should be, let's say, 80 plus, okay? You know, 80 to 100, to give you just a rough basic idea. Now, just because the PO2 is 70 doesn't mean it's way out of line. But I'm going to use emphysema patients for the whole talk kind of thing, just as an example, because we see more of that. So when somebody's working hard to breathe, their respiratory rate is 30, like I said, or higher perhaps. Remember, 99% of the time my vital said respiratory rate is. And is that normal or abnormal? Abnormal. I mean, like these guys hyperventilating a little bit. Normal is about 12 to 14 or 16. So, you know, every vital sign says 20, and you know, when the lawyers will ask me, isn't this guy sick at 20? I said, that's what the nurse will ask her. When they start breathing fast or hyperventilating, we're blowing off our CO2. Okay, so typically, in a normal individual, if we checked an ABG on Harold, who hyperventilates when I start rounding, his PCO2 will drop, or should drop, okay? So a normal individual, if we really worked hard, can probably just get it down to about 30, or maybe a little bit less than that by hyperventilating, okay? Not too much lower than that. And the pH, you know, may drop down a little bit. Remember, if you're hyperventilating, the pH may not change all of a sudden. It's going to take a while because it compensates. It takes a little bit of time. So I won't write that number down right now because it's more of a chronic situation we're talking about. And he's not going to really change his O2 that much by hyperventilating. He might get it up a couple of points, okay? So, but the PCO2 will drop quickly is the only change you'll see in a normal individual who hyperventilates, okay? Now, let's take a COPD emphysema patient with damaged lungs who's breathing about 30 times a minute, and then you're going to get somebody who might have a pH, I'm going to make up some numbers here, let's say 7.30, his PCO2 is going to be about 50, and his PO2 is going to be 60, okay? Now, you guys have all seen ABGs, I'm sure, by now. What I care about when you guys are calling me numbers is these two pieces of information, okay? A, if you give me a guy who has a Guy Collier, I know we'll not do HIPAA violations, but, you know, I think he passed away, so it's okay. This poor gentleman I've known for a couple of years, terrible COPD. He's been, I don't know if he's been on surgical, but I know he's been on PCU and certainly ICU. He I think gets my record book numbers. His PCO2 was 125. His pH, believe it or not, was like 7.33 or something like that, okay? If I did this to one of you, I'd have to paralyze you to make you stop breathing, so your PCO2 goes up, and your pH is likely going to be like 6.8 or something. You'll be pretty acidic, okay? And I know we're not going to talk acid-base stuff here. So when I see a PCO2 of a high number above the 40s, okay, and my pHs are pretty normal, this guy is compensating. He's been like this for a while. If I see a very low number, 7.1, 7.2, like that, or 7.3 with a PCO2 of 50, 60, 70, where their pH is getting more acidic, that's an acute process going on, that something's changing right now that we need to act on. So when you guys call me and say, Dr. Patel, we got his ABG that you had ordered yesterday, and we got the 4 AM ABG, his pH is 7.34, his PCO2 is 85, and PO2 is 60, and he's on CPAP, and we'll talk about that. I won't jump at it because his PCO2 is 80 or 90 because the guy's compensated. So my first triage is, what's his pH? Okay, is it close to normal? Okay, if it's not close to normal, then we'll talk about the ventilator stuff. You know, how high is this? How much do I worry about it? And the last thing I'm looking at is O2 from my eyes. The reason for that is if the doctor you call and says, oh, doctor, this guy's pH is 7.35, his PCO2 is 90, his PO2 is 55, and the guy said, oh, well, just give him 3 liters of O2. What would happen? He has what we call hypoxic drive. He runs his brain on a low O2. If you give him oxygen too much, he will slow down his breathing, his compensation will be reducing his mental volume and stuff, and his PCO2 will go up much more. So now you got a guy who has a PCO2 of 90, PO2 of 50, you put him on 3 liters, if he was on room air at those numbers, his PCO2 will climb up to 120, his pH will drop down further to 7.1, and you went from him talking to you to not talking to you. And then the next thing you do is your RT or code blue, and the guy ends up intubated unnecessarily, potentially. And we'll see that in real life in the ER, okay? The guys in EMS, their job is to save the guy. They don't really have any other agenda, of course. The guy will be at home, he's short of breath, he has severe COPD, he's sitting fine with numbers like this, he has more shortness of breath, so your SAT is 88%, 85% on the finger pulse ox, and we got to put him on 100% oxygen with the non-rebreather, right? Because that's what they all come in on in the ER. By the time they left home to the time they get to the ER guys, doctors saying, oh, well, this guy's unresponsive, we'll have to intubate Mr. Jones, right? And that was from the time span of 10 minutes, 20 minutes getting home to the ER, where his PCO2 now went so high that the guy became unresponsive. And then he gets intubated, and we get him in the ICU and then start trying to work on weaning him off the ventilator. So, questions?
What do you do for him then? Just
Okay, so we'll get to that next. That's where we're going to next. So if you guys have a guy on the floor, 10 p.m., you got a pH that's a little bit acidotic, okay? pH is 7.32, pH is 7.25 and above, let's say. Now, if the guy is awake and talking to you, don't panic, okay? You panic when he's lethargic and obtunded, okay? And he shouldn't be on the 3rd floor, okay? He should be at a minimum on PCU or ICU. So the guy is talking to you. What can you do on the 3rd floor before we move him to the ICU? So the first thing, you say, okay, he's tachypnic, he's short of breath, he's going to get tired out, okay? So can we help him breathe any easier? So that's the next order is, what ventilators can we use? And so you know, we'll say, oh, put him on CPAP, right? So now back to the board.
Back to your board.
So CPAP stands for continuous positive airway pressure. Okay. CPAP is really no different than PEEP on a ventilator. Okay. So it's the same thing, except it's two different devices. If it won't work, we'll make it up. Don't worry. That's okay. Leave it for now. They got the handouts anyway, so. So CPAP, continuous positive airway pressure, and I'll put PEEP here, and we'll come back to PEEP in a little bit. So on the floor, you're going to use CPAP. You're not going to use PEEP on the floor, okay? Well, you guys have the handout, so look at the graphs that I have. Is there a graph with the multiple graphs? Slide number 2, I guess, right?
Yeah, the second.
Okay. Right here, okay? On CPAP, what you're doing is the guy is breathing on his own capacity still. So if I take Harold and put him on CPAP and you just leave him paralyzed, he will die because he's not breathing spontaneously. What CPAP does is it pushes air in constantly. So it's kind of like if you took a hairdryer and stuck it in your mouth on low and left it that way. Okay, you still got to breathe above that low pressure on the hairdryer. So what it's doing is it's putting pressure in the airways and kind of opening up the airways, opening up the alveoli at the end of it, okay? So why is that important in COPD? Well, in COPD you got these, everybody take a deep breath. Hold it there and breathe for the next 5 minutes from that point and higher. One breath. That's what COPD patients are doing. Their lungs are stretched out, all right? Their tidal volumes or total lung capacity and residual volume, what we call in the breathing test that we do, they have a higher lung size, okay? Their lungs hold on to air. So when they breathe out, what happens is their airway, they try to get air in through the bronchial tubes, but as they breathe out, those airways close up before they can get all that air out. Okay, so they got air trapping that we call on pulmonary function test. So that air trapping is why you got this large lung and you can't breathe any more out. Okay, so what does CPAP do? It helps open up that airway to allow them to better exchange that air. Okay, a little bit. It won't fix the emphysema, but it helps them breathe air better in and out. Okay, so it helps that it keeps their alveoli open. It reduces, they don't have to work as hard to breathe now, hopefully. So the first step may be using CPAP on the floor to help them breathe a little bit better. So the next thing you want to do is, if they were in distress and you put them on CPAP, you know, what are the settings on CPAP? Can I pick out people? Who's used the CPAP on your patient? I forget the ICU at least. Floor. No, you're not a floor. You're almost a floor. You're almost a piece. But CPAP, what settings do we put people on? Don't worry. See, that's what I'm getting at. When you call and say, oh, put them on, have respiratory, you put them on CPAP, of course. We're picking one pressure number, okay? So I'll say put them on a CPAP of 10, 8, 12. I mean, you know, make up a number. It doesn't matter. But we'll kind of, by gestalt, say, okay, how big is that person? Because what I have to think about is if it's a skinny person, I don't need a lot of pressure to overcome the weight of the chest. If I need somebody who has obstructive sleep apnea and stuff like that, other reasons we'll use CPAP. They might need higher pressure to overcome that weight of the chest on the lungs, which is compressing that lung. So we'll say CPAP of 10 centimeters. So Harold comes over, puts him on a mask, and turns on the machine and sets it at 10 centimeters of water pressure. So that's the hairdryer setting, is 10 centimeters of water pressure. It can be anywhere from, you don't want somebody with a 4 centimeter, 6 is sort of the low end really to be functional, and higher. And above like 18, 20, you know, it gets to be uncomfortable at that extreme. 20 centimeters of water pressure is a little too high and too uncomfortable for a lot of people. So we'll say 10 centimeters of water pressure or 12 centimeters of water pressure, and let's see how he does. Now you can still use oxygen with that, whether it's 1 liter or 2 liter. So in COPD, you want to be judicious about how much oxygen. I don't care if their O2 sat is 88%, with oxygen. That's fine. I don't want it 92%, 98% because of that CO2 retention, okay? So you put them on CPAP at 10 centimeters and you follow back up. You don't just leave them there and say, okay, how's that working? They might have to adjust it. Well, 10, just still working hard. Harold might come in and say, well, I'm going to try 12 and see how he does. But what I want to know is, did that effectively help his CO2 get lower and his pH, improve to a more neutral condition? So the pH and pH CO2 is what I'll be looking at. I'm really not going to worry about the oxygen, like I said. If it's 55 or 60, that's fine with me. If it's 40, it's a problem. pH has to come up with the CPAP, and the PCO2 has to come down with the CPAP. So I'm going to try to make my pH near 7.35 is my target, okay? To kind of get it close to normal. I don't want it 7.40 either, which is normal for all of us. But for him, I'm going from 7.3 to maybe 7.34, 7.36. That's fine, okay? And his PCO2 anywhere from, if it was 50, if it's coming down to 48 or 45, I'm happy, okay? As long as the guy's talking to you. So now, let's say you've done that, and the next ABG, we do a couple hours later, and his pH is 7.25, his PCO2 is, 65, instead of it going the wrong direction, okay? And he's a little bit more unresponsive or lethargic or confused, altered mental status, because his PCO2 causes CO2 narcosis and confusion, either lethargy, sleepiness, his O2 now, his sats are 84%, 82%. What do you do? Well, so this guy's going the wrong way, obviously. So your next step is saying, well, this guy probably doesn't belong on 3rd floor, okay, because he is changing for the worse. We need to move him now, either to PCU, depending on what his situation is, or ICU. And so we get him down to the PCU and say, okay, well, CPAP's not doing the trick. I don't need to go up to 14 or 16 or whatever. I mean, we could try that if we wanted to waste time. But if the guy's getting worse, my next step may be, if I think he's still salvageable before we'll go to the ventilator, I know I got that, I might try BiPAP. Okay, so now what is BiPAP? BiPAP stands for bi-level positive airway pressure. I don't have a graph on that, but I'll give you an idea what it's like. BiPAP is basically pressure support ventilation, okay, on top of the CPAP. Okay? So what happens is, on BiPAP, you basically have a ventilator except without the intubation. All right, you treat them with a mask and a ventilator, but we can do BiPAP on 3rd floor if the guy's stable. I don't have any problem with that. It's not a big deal. But you want the patient who is stable getting those kind of things instead of somebody who's unstable and you don't know what the next 2 hours are going to do. Are they getting worse? Are they going to improve? So you want them in a more observation situation like PCU or ICU. Bi-level, you got 3 settings on that. Okay. First that we'll do is a rate. To say, like on a ventilator, we're going to put them on a rate. And so the rate is how many breaths that machine is going to give to that patient on top of whatever he might do on his own. Okay? So that if the patient's breathing 20 and you got a rate of 12, doesn't mean he's going to breathe 32 now. Okay? But what happens is the machine will give him a minimum of 12 breaths per minute. Okay? One every, 5 seconds. Right? Yeah. 1 every 5 seconds he'll get a breath. Now, how big is that breath is going to be variable on the patient. How deep he takes in or how shallow he takes in. How do we help improve his tidal volume is based on the next 2 settings. The BiPAP is inspiratory positive airway pressure. So when the guy is breathing in, the pressure that we're setting is going to be, let's say, 14 centimeters of inspiratory pressure. So the machine is going to push air in at whatever, you know, imagine like a simple garden hose. You got whatever the faucet's set at, and the water's flowing out at a constant flow. So on machines, on ventilators, Harold, what's our BiPAP flows? Thank you. Anywhere from 30 to 60 on the big machines in the ICU. The ventilator is going to be 60 liters a minute. So if you had a water hose, in 1 minute you'd put out 60 liters of air. Okay. So on BiPAP, the machine is hooked to the wall oxygen setting. The flow of air coming out of the machine, out of the wall, is regulated by the flow meters on the 15 liters, 5 liters. Remember, 5 liters a minute. Imagine, so if you had oxygen at 5 liters a minute, you'd fill a bucket of air in 1 minute with 5 liters. So think of it that way. So what happens is when you set the bi-level pressure, it's going to push air in at 14 centimeters of water pressure if we set that high pressure. So as the lung is filling up, it's going to fill up and it'll quit pushing air in when it hits 14 centimeters. Okay? And the other setting we'll have is the expiratory pressure. Okay? The expiratory pressure, let's say, will be 8 centimeters. Now, that 8 centimeters is kind of like the PEEP on the ventilator, so that 8 equals almost like the CPAP, okay? So you have two pressures. One is pushing air in when the guy is breathing in at 14 centimeters. Say, hey, you're breathing in, let me give you extra help. Now you're breathing out. I'm going to back off from 14 centimeters and drop the pressure down to 8 to allow that CPAP or PEEP to kind of keep the airway open a little bit at the end of that, instead of dropping it to 0 where as he's breathing out the airway will close down. Okay, so CPAP is the PEEP at that end. Okay, questions or confusion? So that's BiPAP. It's kind of like a ventilator that we can do on the floor. It's portable, obviously. We can do it on the floor. The patient can take it off for lunch and dinner, and he can talk and eat, etc. So it's a little bit more easier. And so that would be for mild respiratory failure kind of patients. Okay. Now the guy, you did an ABG on those settings, and his pH is 7.10, his PCO2 is 90, and his PO2 is 50, and he's obtunded on the PCU. So the next step we got to do is send him home. I'd put him in hospice, but no. So he obviously is a code at that point. He's not breathing. We got to do something right away. And so he would be intubated. So the next step is intubating him. He's unresponsive. He shouldn't be too hard to intubate unless he's difficult anatomy. He doesn't need sedation, So the good thing about intubating those kind of patients is they're out and unresponsive. I mean, you just put the blade down there and try to intubate them. Right, Harold? Right. Intubating him, and then now you got him in the ICU, and so now the vent settings that we use. We know this guy is not breathing. He's unresponsive. You don't know what his respiratory rate will be. It could be 4, it could be 8, it could be 15. So the first things we'll do is put him on what we call assist-controlled ventilation, okay? So if we look at ventilator settings, when do you start? 10:30? The vent settings, let's talk about, basically there's two kinds of ventilators we talk about. Volume controlled, okay, and pressure controlled ventilations. So you can control those two settings in this day and age to keep it simple. Volume control and pressure control ventilation. So let's talk about volume control first. On those ventilators, all these settings can happen on pretty much volume control. So you can have what we call assist control ventilation, okay? Assist control ventilation means you set the machine up to give the patient a given tidal volume and a given rate, okay? And there's a little bit of additional sort of support. So we put PEEP on there, okay? Assist control means if, and there's another thing, is there a CMV on it? Yeah. Controlled mandatory ventilation is what CMV stands for. Imagine the patient is paralyzed, cannot breathe, right? And you put them on assist control, rate of 12, you give them a tidal volume, that's what we call volume control. What can you set? Volume, so you give them a tidal volume, depending on what their disease process is, anywhere from 3 to 5 cc's per kilogram of weight. So that means if somebody, now that sounds like low, if somebody weighs 70 kilos, you know, it's like 350 cc's tidal volume, which is low end. But anyway, it's a little different talk. But let's say you set them at 500 cc's of tidal volume is the setting you put on the ventilator, and a rate of 12. And then you give them PEEP to kind of keep, again, the reason for PEEP is to keep their alveoli open. So if they got pulmonary edema, their alveoli are going to be wet and soggy, and you want to use PEEP to kind of push water out of the alveoli. And then also PEEP to keep the airway, the small bronchial tubes at the end, open so they don't collapse down, okay? So CMV, think of it as in a paralyzed patient who cannot breathe on their own. Same patient who's not paralyzed, who's breathing, same settings, is basically assist control ventilation. So now the guy may breathe 20 times, but every time he gets a breath, minimum breath is 500 cc's. He can take 900 if he wanted to, but the minimum breath he's going to get is 500 cc's. If he breathes 20 times and your setting on the ventilator is 12, he's going to get 20 breaths at a minimum of 500 cc's, okay? So even though you got a rate of 12, he's going to get minimum of 12 breaths, no less than that. He can breathe 30 times if he wanted to, but each breath is going to be this way. So he takes in a breath, it goes to 500 cc's, and then he breathes out. He can do that 12 times at a minimum per minute or more than that. Now, when you add in PEEP, right here, what happens is you're raising the pressure inside the airways by that 5 or 10 centimeters of PEEP that we do, so the pressures increase a little bit to keep that airway open, okay? So that's all that PEEP does at the end. So that's assist control ventilation and CMV. So they're analogous, okay? Both are volume control. You control the tidal volume, you control the rate, okay? Now, the next setting on the ventilator is SIMV, or what we call spontaneous intermittent mandatory ventilation, okay? SIMV is like your assist control, but what happens is you set the setting at 12, you set the machine at SIMV, okay, and you set your tidal volume at 500 cc's. Now, the guy is going to get 12 breaths at 500 cc's, okay? If he's breathing 20 times a minute, the remainder of that 8 breaths is going to be whatever he can do on his own, okay? So if he breathes 100 cc's or 900 cc's, it's up to the patient. So when think of it as a weaning mode for us. A guy is really sick, the guy we just moved to the ICU, we want him on assist control. The next day he's getting better, he's awake, he's doing better. I want to try to get him off the ventilator. I'm going to move him from assist control to SIMV, okay? Now, there's something called pressure support. Pressure support adds, like the BiPAP, when I said we're going to put that inspiratory positive airway pressure at 14 centimeters earlier, when I set the setting on SIMV plus pressure support at 14 centimeters, it's like that BiPAP, okay? So when he's doing that spontaneous breath at 14 or 8 breaths, he's going to get help by that pressure of 14 centimeters. So when he breathes in, that machine is going to give him a boost of air to breathe in, so he won't have to work as hard, okay? So I can change that pressure support to different settings. What we'll use pressure support for, when you have a tube down your throat, you know, the size of an 8.0 tube or 8.5 tube, there's a lot of resistance that you're trying to breathe through, okay? To overcome that resistance of that tubing, the pressure support helps neutralize that resistance, so to speak, okay? So it's not that hard. It's like as if you were not intubated, is what the purpose of that pressure support is, to help you kind of come off the ventilator sooner. And then you can now also add PEEP at the back end of that. So you got SIMV plus pressure support plus PEEP, okay, and your rate. Again, all that is volume control, okay? And when we're weaning them, we'll drop their SIMV rate down. So if the guy was getting 12 breaths and say, okay, he's doing great, let's drop him to 6 breaths. He's doing great, let's drop him to 0. So now all you got is pressure support plus PEEP. That's like your BiPAP, except the guy's intubated, okay? Now, when we are weaning them further, we'll use, basically that comes back down to almost like CPAP at the end, where we can drop the pressure support down to a minimum of 8 or something, or 10, and all he's got is PEEP, okay? So that's kind of like CPAP equivalent at the end when we're weaning them. And if they're doing good, say, okay, he's doing good, I don't need to check an ABG usually. If the guy's awake and ready to get that tube yanked out, we'll just go ahead and extubate him. So those are sort of the quick summary of volume control ventilation. So this is like pressure support plus intermittent mandatory ventilation. This is something else, ignore that. We got all of those, right? Now, let's talk about the next setting is pressure controlled ventilation. When somebody who we have with asthma, bad pneumonia, or maybe perhaps COPD with a bad pneumonia, when we got them on assist control and 500 tidal volume, the RT will say, you know, this guy keeps alarming. His pressures keep going off on the ventilator. So when the machine is pushing in 500 cc's of air, the lungs are stiff, and the pressure in the airways rises. You're trying to jam air into a stiff thing, and the alarms will say, hey, it's peak pressure. Peak pressure, which is, you know, the point up here, is going up to, you know, 40, 50, 60. And the worry we have about that is when the pressure is that high, you're trying to jam air into something stiff, there's going to be a weak point somewhere that's going to pop, okay? And that will cause what we call barotrauma or pneumothorax. And you've seen patients with subacute emphysema as well, so that's barotrauma. So when their pressures are too high, they have disease where their lung can kind of collapse down from that. So we want to try to minimize that high pressure. We'll go to pressure control ventilation. So now the difference in pressure control and volume control is we're setting the pressure, the high peak pressure that the machine will go to as their top point. It won't give them a fixed volume, okay? On the volume control, we say 500 cc's, we don't care what the pressure is. It's going to go in 500 cc's. In pressure control, we're going to say we don't care what the volume of air that goes in. All we care about is we don't want to raise that peak pressure too much. So we'll set a pressure setting of like 30 centimeters or 35 centimeters as a peak pressure, okay? And whatever air that will go in, it could be 100 cc's, it could be 600 cc's, breath to breath, it may be different, okay? But the fixed thing is the peak pressure. And the peak pressure will be additive of the PEEP that you got them on, because you got, you know, 8 of PEEP on the machine. There's no pressure support on pressure control. So on pressure control, all you do is set your oxygen setting, your rate, and your pressure, okay? So the benefit of that is you're avoiding barotrauma. Now again, it's uncomfortable sometimes for that patient, so you have to have them pretty sedated as well. So my personal belief is we're usually never paralyzing a patient unless we absolutely have to. The reason for that is it gets complicated in paralyzing a patient. They're easy to control from the standpoint of ventilation and other stuff from nursing care perhaps, but you know, you don't want to be paralyzed, and the risk is you're not adequately sedated. Okay? And the more immobile you are in the bed in ICU, the higher the risk for things, right? DVTs, sores, etc., and complications. And the longer you're on the ventilator, the risk for pneumonias. Okay, 50% of patients beyond 2 weeks will have a pneumonia on a ventilator. So you're trying to minimize their time on the ventilator, and paralyzing extends their time on the ventilator potentially. So pressure control ventilation we use on really sicker patients, ARDS, bad pneumonia, asthma, etc. Those guys that are really having a hard time on the ventilator, where we got to sedate them more, their peak pressures are high, and we'll use pressure control ventilation. What did I leave out so far?
Sounds pretty good.
So how long do we keep them on the ventilator? You got them set on the ventilator. We're checking ABGs daily. We're checking chest x-rays. The reason we get daily ABGs, if not more frequent, is obviously see if our setting is not like one setting and we're done. Once you make a change in the setting, I might want to get an ABG a couple hours later to say, okay, what did that setting change do to the physiology? Second thing is we want to get x-rays. We get them daily in the ICU on the ventilator to look for any trauma, injury, change of pneumonia, the guy's improving, etc. So we want to look for any subacute emphysema. Position of the endotracheal tube, can get moved. You might rotate the patient to the side, and the tube might, be pulled out higher or go in deeper. We want the endotracheal tube just above the carina on the x-rays to be seen. So we're looking at tube positioning, etc. on the x-rays that we're doing daily. And once the patient is improved on their underlying condition, whether it's pulmonary edema, COPD, asthma, pneumonia, etc., we want to start weaning pretty much as soon as we're intubating. But by the next day we want to say, where are we at? How long do we go depends on what their underlying condition is. So we want to be weaning them on a day-to-day basis and see if they can make it. If they can't make it and we're stuck for a period of time, we'll try to start thinking about doing a tracheostomy. Typically, the standard is about 2 weeks. Doing early trach is like 10 days and less. The guys would be really aggressive in doing a trach. The problem that I find with that thing, doing an early trach, it may get us off the ventilator by a few days sooner perhaps, but they're stuck with that trach for 6 weeks or longer. Okay, even they're off the ventilator, they go home. They got to get the tube downsized and they got to get followed, and so there's some controversy about how soon you do things like that. To me, I'd rather kind of, if we know the guy cannot come off the ventilator and we're stuck on the ventilator and he needs a trach, whether it's 10 days to 2 weeks, we'll be looking at doing that trach. Sooner than that, I think, is a little premature from my viewpoint. But at 2 weeks, they're not coming off the ventilator. We seriously need to be looking at doing a trach at that point in time. And some might, at that time, if they're coming off the vent in a couple of days, we're not going to do a trach. But if I can see in the future it says, well, this guy's not coming off in the next 3 to 5 days, at least, then he gets a trach. Complications with ventilators, like I said, is barotrauma. The nurses and RT are suctioning, so you can get trauma in the tracheal area, bleeding. Certainly you introduce infection. It's better because we have these closed circuits now where you don't disconnect the patient from the ventilator, go down and suction. That has helped a big deal. Trauma to the trachea from the endotracheal tube. Of course, being sedated, risk for immobilization, contractures of muscles, DVTs, of course, risk for ulcers, etc., the sicker they are, and certainly pneumonias. And what else? Did I forget something else? Is there anything else on there?
I don't know.
All right, any questions? So let's start at like a real quick verbal description of the mechanical. And what I gave you, those quick little slides, and I kind of hope they were adequate, but it could be done better. All right, any other questions? If you're asleep, we might intubate you. All right, thank you.
Thank you.
Thank you.